Hello, this is Dr. Catlin. This is a recording of lecture on 16A, cardiomyopathy, in your Pearson text. It starts on page 1155. I just broke up the word here. Heart myomusculopathy disease. Heart muscle disease is cardiomyopathy. Heart muscle has trouble pumping. It's enlarged, thick, or rigid, can be acquired or result of other diseases or therapies. It may be inherited. Some causes are unknown. There are several different types of cardiomyopathy, which we're going to discuss. Severe dilation of the heart chambers without heart valve abnormalities. Heart muscle stretches, weakens, and leaves insufficient perfusion of organs. The heart may become enlarged, thick, or rigid. Every type of cardiomyopathy progressively weakens the heart, decreases its ability to pump blood and maintain a regular rhythm. Risk factors in cardiomyopathy. Family history of cardiomyopathy, heart failure, or sudden cardiac death. As it'll make more sense as we talk about the different cardiomyopathies. Long-term high blood pressure, you think about the constant pressure that left ventricle is pumping against, leading to an enlarged, thickened left ventricular wall. Heart conditions, heart attack, coronary artery disease, infections of the heart, obesity, long-term alcohol abuse. Often long-term alcohol abuse can lead to nutritional deficiencies, and nutritional deficiencies themselves, especially thiamine or B1, which is also very common deficiency in alcohol abuse, damages the heart. Illicit drug use, cocaine, anabolic steroids, amphetamines. We'll talk more specifically on the cardiomyopathy that's caused by cocaine. Iron buildup, hemochromatosis, which is extremely high iron levels, affect the heart, lead to cardiomyopathy. Some inflammatory conditions such as sarcoidosis, certain chemo drugs and radiation treatments, metabolic disorders such as diabetes and thyroid disorders. I mentioned sarcoidosis already. That's a connective tissue disorder. Cardiomyopathy classifications. We're starting with dilated cardiomyopathy, which is exactly that. See how dilated the left ventricle is. Left ventricle enlarges and loses its pump action, most often in middle-aged men. Most common cause is coronary artery disease and heart attack. Although, a lot of times they don't even know the cause. It can, if it's not coronary artery disease or heart attack, it can be exposure to toxins and certain metabolic conditions and infections. There can be some reversible cardiomyopathy, dilated cardiomyopathy related to cocaine abuse, chemo drugs, pregnancy, or systemic hypertension. Your end diastolic and end systolic volumes increase because with this is so dilated, this muscle is stretched out, it can't squeeze very well, so it doesn't empty completely. So you have blood left over it at the beginning and end of your systole. Decreased left ventricular ejection fraction and decreased cardiac output. Keep a note of that because it may be different on some of these cardiomyopathies. So the muscle can't squeeze very well, and you have an increased systolic end diastolic and end systolic volume. So your ejection fraction is how much is percentages squeezed out with each pump. Percentage is decreased. Sorry, the computer was doing something. Percentage is decreased because not all of it gets pumped out, which means also your cardiac output is decreased. This dilated cardiomyopathy, it's more common in men than in women. 1/3 of dilated cardiomyopathy is inherited, usually occurs between the ages of 20 to 60. It often will impact the right and left ventricle. That's why your end systolic and diastolic are affected. I want to talk about the other cocaine-induced cardiomyopathy. This is where cocaine and alcohol can lead to dilated cardiomyopathy. Cocaine-induced, the deprivation of myocardial oxygen coupled with increase in the demand for oxygen, which both lead to a reduction in coronary blood flow. And this is an acute state. As soon as the cardiac function is resumed, the dilated cardiomyopathy may resolve. And as I mentioned in a previous lecture, you can still have ischemia, myocardial infarction with the cocaine, but the dilated cardiomyopathy should resolve. Chronic alcohol use, heavy or binge drinking, leads to an alcohol toxicity in the heart muscle, and those metabolites from that toxicity lead to a dilated cardiomyopathy. Another is called the broken heart syndrome. It was found in, or what are they coined, I guess you could say, in Japan with some of the big earthquakes and traumas. It's called Takotsubo cardiomyopathy, Takotsubo, Takotsubo or broken heart syndrome cardiomyopathy. There's an abrupt apical ballooning due to substantial increase in the catecholamines, leading to an injury and dysfunction within the heart. Usually it's a result of severe emotional, physical stress from a sudden illness, a loss of a loved one, a serious accident, or a natural disaster such as an earthquake. 90% with this broken heart syndrome or Takotsubo cardiomyopathy are women between the ages of 58 and 75. It will resolve without damage once the stressor is relieved, acute stressor is relieved. Clinical manifestations for dilated cardiomyopathy: dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, weakness, fatigue, peripheral edema, ascites, S3, S4, atrial valve regurg. Now think about it, this dilated cardiomyopathy, you have increased end systolic and diastolic, leading to right and left-sided heart failure. So if you look at these, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and weakness, fatigue are all signs of your left-sided heart failure. Peripheral edema and ascites are signs of right-sided heart failure. Atrial valve regurgitation is due to the increasing pressures in the heart. S3 is usually heard with a fluid overload. S4 is due to the lack of stretching anymore of that left ventricle. This dilated cardiomyopathy is really high risk for sudden cardiac death if they go into a ventricular arrhythmia, which can occur more often with a valve problem. Hypertrophic cardiomyopathy. Hypertrophic. I'm sorry I cut off part of this picture, but this left ventricle is this skinny little slit. Instead of all this, if you follow from this valve down, that's about all you get for the left ventricle because the septal wall is so grossly dilated or hypertrophic. So hypertrophic ventricular muscle mass, usually inherited, it occurs on the left ventricle, small end diastolic volume. end diastolic. Systole is when its ventricle squeezes. End diastole. Let me think a minute. I always have to picture this and think my way through it. When you think of your blood pressure, systolic, diastolic. Systole is when the ventricles squeeze and the blood is pumping out. End of systole. End of systole, the atrium okay, so the atrium's full, the ventricle has squeezed out. Then you have diastole. When it's relaxed, the atrium squeezes into the ventricle. At the end of that, that's it. Okay, so the atrium has squeezed into the ventricle. At the end of diastole, when all of that's done, because it's just the skinny little slit, there's very little volume in there, so small end diastolic volume. And because there is so little in there, there's very little cardiac output because there's nothing to fill to pump out. Also increased risk for life-threatening dysrhythmias. Sorry, I had to think through that a minute. It can develop at any age. It tends to be more severe if it becomes apparent during childhood. Most affected people have a family history of this disease, and some genetic mutations have linked to this hypertrophic cardiomyopathy. Symptoms are dyspnea, fatigue, dizziness, and palpitations, which makes sense because you have very little cardiac output because the left ventricle is so skinny. So you don't have much oxygen perfusion. You're going to be tired. You're going to be dizzy, have palpitations because there's a risk of arrhythmias, and you're going to have a harsh systolic murmur at the left sternal border. Okay, clinical manifestations of this hypertrophic cardiomyopathy. I mentioned the shortness of breath, more common during and after exercise because the cardiac output's so low. Your syncope, dyspnea, angina, palpitations, arrhythmias, fatigue, orthopnea, paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea means it comes and it goes, and it occurs at night, and it's a shortness of breath. So they could be asleep and suddenly sit up, gasping for air, and then it resolves. Comes and goes, paroxysmal nocturnal dyspnea. And the angina results from the ischemia caused by enlarged ventricular muscle and decreased perfusion. They commonly will have atrial fib and ventricular dysrhythmias. I told you about the harsh systolic murmur, possibly having an S4, can lead to congestive heart failure and sudden cardiac death. Restrictive cardiomyopathy. Restrictive, rigid ventricular wall due to scarring and fibrosis. This muscle is very thick. It is restricted. Hypertrophic means it's this narrow because of the thick septal wall. And restrictive is stiff. It restricts, it doesn't expand. It's the least common. It's usually in older individuals. Decreased ventricular compliance impairs ventricular filling. So because it doesn't stretch out as it fills, it limits how much can go in there, which leads to a decreased cardiac output because it can't fill very much. It can still squeeze out the blood, so you have ejection fraction doesn't change, but it can't fill very much, so it decreases your cardiac output. Incomplete ventricular filling. It may occur after a heart transplant or from iron buildup, hemochromatosis. I think it's restrictive is the one that they don't do. I'm not positive. I have to look it up whether it's the hypertrophic or restrictive. That they don't do heart transplants. I will have to let you know. Clinical manifestations for restrictive may be asymptomatic or have very few symptoms. May worsen as the heart function decreases. Sorry about the typo. May develop exercise intolerance, fainting, fatigue, chest pain. Can lead to jugular vein distension, common to have an S3 and S4. Again, fluid overload and the hypertrophy, or not hypertrophy, the stiffness of that left ventricle. Arrhythmogenic right ventricular dysplasia. Very rare, often diagnosed before the age of 40. It's the 1/5 of sudden cardiac deaths before the age of 35 are due to this arrhythmogenic right ventricular dysplasia. Muscle in the right ventricle is replaced by fatty and fibrous scar tissue, which leads to heart rhythm problems, often caused by genetic mutations or heredity. High risk for ventricular tachyarrhythmias and sudden death. Hold on. Okay, let's go to the next one. Complications of cardiomyopathy are heart failure, blood clots, heart valve problems, arrhythmias, cardiac arrest, or sudden cardiac death, which makes sense. Diagnostic studies, we've talked about echocardiograms, EKGs, often ambulatory EKG monitoring like a Holter or something because of watching rhythm changes with activities. Chest x-ray looking at heart size, looking for heart failure hemodynamic studies, looking at all the pressures in the different chambers of the heart, radionuclide scans, looking at that muscle tissue, cardiac catheterization, coronary angiography where they can actually visualize, myocardial biopsy, I guess if they're looking, and genetic testing if they're looking for more of a genetic or inherited type of disorder. Or diagnosis begins with a thorough history and physical assessment to rule out other causes of heart failure. Treatment options: low salt, healthy body mass index, smoking cessation, avoiding alcohol, taking your vaccinations, that's to protect those valves, exercise training unless they have restrictive cardiomyopathy or arrhythmogenic right ventricular dysplasia. Those two, they do not have exercise training. Different medications, we've talked about all these. Don't worry about Ibramine interventions. We're going to cover some of these here. So pharmacological management, we've talked on ACE inhibitors, ARBs, beta blockers, spironolactone, calcium channel blockers, cardiac glycosides, which is your digoxin, the various diuretics, nitrates, vasodilators, antiarrhythmics, B, natriuretic peptide. We're going to talk more about the BMP peptide that in our heart failure, but it can help with cardiomyopathy. Inotropic agents like dopamine to help with that squeeze. Possible anticoagulants if, like with the atrial fib or some rhythm problems, valve problems that can obstruct blood flow. Your beta blockers are used with caution in your dilated cardiomyopathy, or usually not used in dilated cardiomyopathy because that ventricle is already so dilated and you do not want to relax the heart muscle with that beta blocker. Here's just some pictures of surgical management for cardiomyopathy. They can do a heart transplant. Here's some pictures here. A biventricular pacer to help sequential squeezing in the pressures, and I think I have another picture talks about that. This is your LVAD, left ventricular assist device. They have some that are worn actually partially like on the outside and the inside, some that are planted completely inside, as you can see in here. Cardiomyopathy in the older adult. Less common in older adults than young adults and children, or dilated cardiomyopathy is less common in older adults. Restrictive is more common in the older. Cardiomyopathy is a blanket term to describe heart failure or dysrhythmias having no well-defined cause that cannot be attributed to a specific cardiomyopathy. Treatment depends on symptoms and the health of the individual patient. The hypertrophic cardiomyopathy in the older adult usually has low symptoms, low mortality and morbidity, so they do not support putting an internal defibrillator in the elderly adult with the hypertrophic cardiomyopathy. Nursing diagnosis can be your decreased cardiac output related impaired left ventricular filling, contractility, outflow obstruction, fatigue related decreased cardiac output, excess fluid volume related to compensatory mechanisms, deficient knowledge, and grieving. So if you think about your interventions would go with these and your outcomes also. So you want to monitor your cardiac output, encourage periods of rest, elevate head of bed. These are interventions. Avoid Valsalva maneuver, administer medications to decrease the cardiac workload, increase contractility, administer supplement oxygen, monitor vitals and O2 sat, monitor the BNP levels, auscultate heart and lung sounds. As the heart pump fails, the stroke volume and tissue perfusion decrease. Decreased cardiac output stimulates the sympathetic nervous system, which increases the heart rate, trying to restore the cardiac output. That's why cardiac tachycardia is so common with cardiomyopathies. Vasoconstriction leads to increased diastolic pressure, but this compensation fails later. So initially, the body, the vessels will constrict to try to increase the diastolic pressure, but they can only do that for so long. O2 sat gives a measure of the gas exchange and tissue perfusion. The BNP is a hormone produced by your heart and released in response to changes in the heart. I'm not going to make you memorize the levels for the different age. Okay, so you want to monitor their fluid volume, restrict fluids, monitor INO, daily weights, abdominal girth every shift, lung sounds, heart sounds at least every 4 hours, recordings of your hemodynamic measures. When fluids are restricted, remember ice chips, oral care candies. Also remember that edema is not diagnostic for your fluid overload. You may have edema, but the diuretics are decreasing your circulatory volume, so you're really watching your weight and your INO. With your weight, 2.2 pounds or 1 kilogram of weight equals 1 liter of fluid. 1 liter equals 1 kilogram, which equals 2.2 pounds. 1 liter to 1 kilogram. So every kilogram of weight gain or loss is 1 liter of fluid gain or loss. You're measuring your abdominal girth for venous congestion. This will also impact your nutrition, so you're watching their albumin. Definitely closely watching your respiratory status, your lung sounds, blood pressure, heart rate, oxygenation. That's your hemodynamic measurements. Discharge teaching, low sodium diet, dietitian consult, what to expect, what treatment options are there, what community resources do they have, having some kind of home care services, may need some counseling, rationale and adverse effects of medications, when to report what symptoms, and if cardiac transplant is an option for them. That is the end of this recording.